Hello and welcome to Oncology for the Inquisitive Mind, and a very special start to a very special series that we're doing. We are doing a ESMO retrospective. Josh and I were running around like headless chickens for the better part of a week, trying to get to as many presentations as we could. However, we are bringing in some experts, some of the smartest people that we know, to do a little bit of a review of what happened at ESMO 2024. And we've got one of them here. Dr. Geoff Chong, who's a medical oncologist that specialises not only in GI cancer, which will be his focus today, but also in lymphoma. He has completed an MD at the Ludwig Institute for Cancer Research and has spent 3 years at the Royal Marsden Hospital in London. He works at multiple public centres and has developed several booming clinical trials units. Geoff, thank you so much for coming on to Oncology for the Inquisitive Mind for this GI retrospective.
Thanks, Michael and Josh. Today we'll go through the GI-focused presentations from ESMO 2024.
Geoff, can I ask one question just before we start? I always digress. This is my role in the podcast. What do you define as a booming trials unit? Is that like a new metric we should all aim for?
It's a trials unit which keeps on growing.
Amazing. We'll have to bring you back on to talk to you about how you did that another time, but obviously that's not the focus of today. I'll stop talking just for the purposes of why everyone's listening.
Yeah, so look, there was actually quite a lot of really interesting data presented at ESMO 2024. Thought I'd categorize the GI studies into positive studies, negative studies, and the interesting studies. So first, there were actually a few HCC or hepatocellular carcinoma studies presented. First was Apollo. This was a Chinese phase 3 study of anlotinib, which is a multi-targeted TKI which inhibits VEGFR 1 to 3, PDGFR, FGFR 1 to 4, and c-KIT, plus a PD-1 inhibitor called pembrolizumab versus sorafenib, which is a less commonly used first-line treatment now. They randomized 650 patients 2-to-1 to the combination of anlotinib / pembrolizumab or sorafenib. So eligible patients were biopsy confirmed, unresectable, unsuitable for loco-regional treatment with Child-Pugh A to B7 cirrhosis. This is broader than the current indication for sorafenib or lenvatinib or atezo-bev for that matter, although there were very few B7 patients enrolled. The dual primary endpoints of PFS and OS were both met. The hazard ratio for PFS was 0.53 and for overall survival was 0.69. The survival improvement was 3.3 months at the median. The main toxicities of anlotinib and pembrolizumab were hypertension and bleeding. They didn't really talk much about the immune-related adverse events, but they commented that the rate was low for what that was worth. So this was certainly an interesting result given the negative LEAP-002 trial, in which compared lenvatinib plus pembrolizumab to lenvatinib plus placebo, which has been previously presented and published. So the next study in HCC was actually LEAP-012. So even though LEAP-002 was negative, this particular study, LEAP-012, was positive. Although this is a different target population, likely a less advanced population with lesions still amenable to TACE. So in this study, 480 patients were randomized in a phase 3 study to TACE plus lenvatinib plus pembrolizumab or TACE plus placebo. Only Child-Pugh A were eligible. The primary endpoints were both progression-free survival and overall survival. PFS was improved with the lenvatinib pembrolizumab combination versus placebo with a hazard ratio of 0.66, p-value of 0.0002. The PFS gain was 4.6 months at the median. Overall survival was immature, but there was a trend to improvement with len-pembro. As expected, there was increased toxicity in the experimental arm compared with placebo, with the most prominent adverse events being hypertension, proteinuria, thrombocytopenia, palmar-plantar erythema, diarrhea, and fatigue, really all as expected. The main question mark over this study is whether it is better to initiate checkpoint inhibitor-based therapy at the same time as initiating TACE, or whether systemic therapy should be reserved for after TACE failure, which is currently the case. Just moving to neuroendocrine tumors, The Cabinet study was a phase 3 US alliance study examining cabozantinib in patients with pancreatic neuroendocrine tumors and extrapancreatic neuroendocrine tumors previously treated with tyrosine kinase inhibitors or PRRT. Cabozantinib is an oral multikinase inhibitor targeting VEGFR, c-MET, AXL, and RET. Each cohort was randomized 2-to-1 to either cabozantinib or placebo. Primary endpoint was PFS, and crossover was allowed at disease progression. Eligible patients had grades 1 to 3 neuroendocrine tumors, but they had to be well to moderately differentiated. Progression had occurred within the last 12 months on either everolimus, sunitinib, or PRRT, and concurrent somatostatin analog treatment was allowed. So extrapancreatic NETs were 2/3 grade 2 with a median of 2 prior therapy lines, including 60% with prior PRRT and 1/3 with prior chemotherapy, so they were quite heavily pretreated. Pancreatic NETs were also at least moderate risk with 60% grade 2, median 2 to 3 lines of prior therapy, including 60% PRRT and nearly 2/3 prior chemotherapy. So both cohorts demonstrated substantial and statistically significant PFS benefit with hazard ratios of 0.38 for extrapancreatic NETs and an impressive 0.23 for pancreatic NETs. There was no overall survival benefit seen, likely due to crossover. Subgroup analyses showed benefit across all subgroups, including primary tumor site, grade, and prior treatment. Of note, 2/3 of the cabozantinib patients required dose reduction, and the main grade 3 toxicities were fatigue, diarrhea, and hypertension. So these data are very welcome, as extra treatment options are really sorely needed for neuroendocrine tumors. It's also really good that they included grade 3 patients, although poorly differentiated tumors were not. So moving on to anal squamous cell cancer. So the INTERACT-2 study was presented by Sheila Rao from the Royal Marsden. This study built on the phase 2 INTERACT study, the original INTERACT study, which established carboplatin and paclitaxel as a standard first-line therapy for advanced inoperable anal squamous cell carcinoma. So INTERACT-2 was a phase 3 trial of carboplatin paclitaxel plus either retifanlimab, which is a PD-1 inhibitor, or placebo. Primary endpoint was PFS. They enrolled 300 patients. 82% had metastatic disease, 3% had HIV, and 90% had PD-L1 expression of at least 1%. The study was positive for the primary endpoint with a hazard ratio of 0.63 and an improved PFS of 2 months at the median, p-value 0.0006. Crossover post-progression was allowed. However, the overall survival actually did appear to be improved with a hazard ratio of 0.7 and a p-value of 0.02. There were no new safety signals with retifanlimab. So this is not an unexpected result given that these tumors are squamous cell cancers. This does confirm the role of PD-1 inhibition in the frontline treatment of advanced inoperable anal squamous cell carcinoma. The obvious next step would be to incorporate checkpoint inhibition into the frontline treatment of localized disease, which would be an advance given that we've been using the current treatment for many years now. So then I might move on to the interesting studies. Just got 2 studies here, well, really 3 studies. The first being MOONLIGHT. So this is a German study, investigator-initiated. It's a complex 4-arm study involving patients with metastatic HER2-negative gastric and esophagogastric junction adenocarcinoma. The idea was to investigate immunotherapy and/or chemotherapy intensification of the standard FOLFOX plus nivolumab. One of the arms was FOLFOX plus doublet immunotherapy with ipilimumab and nivolumab. Another arm investigated FOLFOX induction followed by ipilimumab/nivolumab maintenance. Between 40 to 60% of patients had combined positive scores for PD-L1 of at least 1%. So this was just a phase 2, but numerically, FLOT plus nivolumab seemed to have higher response rates, PFS, and overall survival compared to the other arms. Toxicity was judged to be acceptable, although it has to be said that the grade 3 to 5 treatment-related AE rate was 67%. Nevertheless, it would be worth performing a randomized study of that triplet using FLOT plus nivolumab versus the standard FOLFOX plus nivolumab. The next studies I'll discuss were the niche 2 and niche 3 studies. So these are part of this really interesting niche series of studies from the Netherlands, studying the effect of checkpoint inhibition on mismatch repair deficient colon cancer in the preoperative setting. Essentially, they're further demonstrating the concept that immunotherapy is most effective early in the cancer life cycle, and we've seen this with multiple cancers. So niche 2 had already demonstrated a very high pathologic complete response rate after 2 cycles of nivolumab plus ipilimumab. This year's update, after a median of 36 months follow-up, documented a 100% DFS at the 3-year mark. And they also reported the ctDNA analysis, which showed that all 108 patients were ctDNA negative 3 weeks after surgery. So niche 3 had a similar design, but substituted the LAG-3 inhibitor relatlimab for ipilimumab. Enrolled 59 patients with DMMR colon cancer, and they all received 2 cycles of this combination followed by surgical resection. Pathologic complete response rate was 68%. 10 patients experienced grade 3 to 4 immunotherapy-related adverse events, which comprised colitis, hepatitis, and thyroid dysfunction. Both of these studies require longer follow-up to determine if patients are actually cured using this approach. The other open question is whether surgery is actually required for all patients treated with upfront checkpoint inhibitors, and how best to determine which patients might actually require surgery. And then moving on to the negative studies. So TOPGEAR, been waiting for a very long time for the results from this study. Firstly, I'd like to congratulate Trevor Leong and the study team at AGRTG for leading this study to completion through a 12-year accrual period across 70 sites, 15 countries. The context is that since the very first positive adjuvant trial in gastric cancer, which was the US Intergroup 116 study, so-called McDonald study, multiple phase 3 trials have failed to show benefit for post-operative radiotherapy for gastric cancer. However, there have been multiple phase 3 trials demonstrating survival benefit for the addition of perioperative chemotherapy to high-quality surgery. TOPGEAR sought to determine if adding preoperative chemoradiation to perioperative chemotherapy plus surgical resection would improve overall survival. Due to the long accrual period, the standard for perioperative chemotherapy changed from ECF to FLOT. So a third of patients received FLOT on this study. 1/3 of patients had esophagogastric junction tumors. The pathological complete response rate was doubled in the pre-op chemorads arm, but there was no improvement in either progression-free or overall survival. So in the context of the other negative phase 3 trials, we can conclude that there is no role for either pre or post-operative radiotherapy in the curative treatment of esophagogastric adenocarcinoma. Second negative study was RAMTAS. So this was possibly a slight surprise. This was an investigator-initiated German phase 3 trial designed to see if adding ramucirumab, which is a VEGFR2 monoclonal antibody, to trifluridine/dapirocil, or TAS-102, for late-stage advanced colorectal cancer. We don't have access to ramucirumab in Australia, but the RAISE trial did demonstrate improved survival with the addition of ramucirumab to FOLFIRI after first-line bevacizumab-based chemotherapy. Of course, the other important context is that the SUNLIGHT trial recently demonstrated improved survival with the addition of bevacizumab to TAS-102. So in this study, RAMTAS, interestingly, overall survival was actually not improved by the addition of ramucirumab, even though the PFS was significantly improved with a hazard ratio of 0.77. It has to be said that the difference at the median was only 0.3 months. The lack of overall survival improvement may have been due to subsequent therapies. Also, it is worth noting that the RAMTAS cohort was more heavily pretreated than SUNLIGHT, including a higher percentage of patients with prior anti-angiogenic therapy. So that may have also been a factor. And then we come to SOLARIS. So the final negative study was the saddest of all. We all desperately wanted confirmation of the SUNSHINE phase 2 study, which suggested a PFS improvement with the addition of high-dose vitamin D to first-line chemotherapy for metastatic colorectal cancer. SOLARIS was an alliance phase 3 study of 450 previously untreated metastatic colorectal cancer patients randomized to chemotherapy plus bevacizumab, plus either low-dose or high-dose vitamin D3. Unfortunately, there was no PFS difference between the arms. In the subgroup analysis, there seemed to be benefit in left-sided tumours, but this would require confirmation in a separate trial. So I think we can say that at this time, we should not be adding vitamin D to our metastatic colorectal cancer patients' treatment. So in summary, ESMO 2024 produced really interesting data from large randomized trials in the GI space. And, I think we're seeing increased integration of immune checkpoint inhibition into treatment paradigms, as well as targeted therapies. The ongoing challenge will be to determine if further intensification of checkpoint blockade and or inhibition of novel targets will be sufficient to make further gains in patient outcomes, or do we need to adopt new agents, so agents with novel mechanism of action, things like T-cell engagers or cellular therapies even.
That was a brilliant summary, so thorough, and I really like that you gave special attention to the negative studies as well, because that's something we weren't able to do. Before we sign off, because you've filled the brief completely, I have really no notes, but one of the questions we always like to ask is, what study really got you excited, or what study do you think is going to have the greatest impact in, say, the short to medium term that you saw at ESMO 2024?
So as always, this depends on drug availability, and that depends on reimbursement and obviously PBAC approval. Which of these is most likely? I mean, we've got Cabinet with cabozantinib, we've got the LEAP study and also Interact, and Apollo. I think Apollo is less likely. I would really like to see Interact get up. We really need to improve the treatment of patients with metastatic anal squamous cell carcinoma. There have been really few and far between. And in fact, the last data we had was actually the Interact original study, which established carboplatin and paclitaxel as a standard for first-line treatment. But to improve that further with the addition of immunotherapy would be really great. I'd really like to congratulate actually the Interact investigators for performing randomized studies in this space, because they've been very rare. So it's a great credit to them.
I completely agree. We picked the same study, Jeff. The Interact study was well deserving of its place in the presidential symposiums. Jeff, thank you so much for your time and coming on to the show. We really appreciate you giving us the GI insight from a GI specialist. Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions, with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.